TOG 2024 April issue. Heavy menstrual bleeding in adolescence. Who to investigate and how to manage it. Key content. Adolescent heavy menstrual bleeding, HMB, is commonly related to hypothalamic pituitary ovarian axis immaturity, which improves with age. Medical treatment for adolescent HMB consists predominantly of hormonal contraceptives. Preparation choice depends upon patient preference, comorbidities, and coexisting conditions. Acute adolescent HMB is rare. Background. There are 1.2 billion adolescents in the world, comprising 16% of the population. Menstrual health is becoming increasingly recognized as a major health issue for women and girls. In 2022, the World Health Organization issued a statement on menstrual health, highlighting its impact on education, non-discrimination, and gender equality. The UK government cited menstrual health as a priority area within the Women's Health Strategy for England, emphasising the potential impact on education and workplace attainment as a direct result of unmet need. Heavy menstrual bleeding, HMB, is the most common gynecological reason for referral of adolescents to secondary care. The prevalence of HMB in adolescents varies widely in population-based studies, ranging from 4.8% to 37%. Depending on definition, geographical location, and socio-economic status. The National Institute for Health and Care Excellence, NICE, defines HMB as excessive menstrual loss which impacts an individual's quality of life, or where sanitary products are changed 1 to 2 hourly, or where menses last longer than 7 days. HMB has physical and psychosocial consequences with higher rates of fatigue, decreased verbal learning and memory, depression, and school absenteeism reported. Adolescent menstrual cycles. The mean age of menarche in the UK is 12 to 13 years old. Over the past century there has been a notable decline in age of menarche, which has been attributed to improved nutritional status and reduction in chronic disease. African American ethnicity, higher childhood body mass index, estrogen receptor A, and leptin gene polymorphisms are also associated with earlier menarche. A typical adolescent period lasts between 2 to 7 days and occurs every 21 to 45 days. In the first year following menarche, 50% of menstrual cycles are anovulatory, although, by 2 to 3 years post-menarche 75% of adolescents are ovulating regularly. Therefore, the most common cause of HMB in adolescence is anovulatory cycles resulting from hypothalamic pituitary ovarian, HPO, axis immaturity. HMB commonly improves with time, and reassurance may be all that some adolescents and their carers need from a healthcare professional. Others need a greater level of support, and this article will outline the evaluation of an adolescent presenting with HMB, guiding further investigations, and navigating the range of management options available. Clinical evaluation for heavy menstrual bleeding. Although some girls are familiar with medical settings, for many this will be their first hospital visit. They may feel anxious, and negative experiences can affect future engagement in healthcare. Attention should be taken to create a comfortable clinical environment to make girls feel at ease, and empower them to express their opinions and concerns surrounding their symptoms and treatment. History. The clinical history should be ideally taken both with and without a parent or carer present, to allow clinicians to explore sensitive or confidential subjects. Questions should focus on establishing the frequency and heaviness of bleeding, associated symptoms or risk factors for an underlying pathological causes, impact on quality of life, and highlight any safeguarding issues. Box 1. Girls should be encouraged to keep a diary of their menstrual cycles on a phone app or paper to aid evaluation. A sexual history should always be taken in the absence of a caregiver, including details and ages of partners, and assessment of any potential issues that would raise safeguarding concerns. Box 1. Clinical history for heavy menstrual bleeding in adolescence. Examination. An examination is rarely needed, however when performed it should assess for complications from bleeding, or signs of an underlying cause. It may be useful to reassure the girl at the start of the consultation if an examination will not be needed, as this may reduce appointment-based anxiety. A chaperone must be present for any clinical examination, with the girl having the choice of a parent or carer present too. Investigations. When and how? Generally, treatment can be initiated without additional investigations, Although, NICE recommends that a full blood count, FBC, should be carried out for all women presenting with HMB in conjunction with treatment. The British Society for Paediatric and Adolescent Gynecology, Brit SPAG, recommend that ferritin is checked alongside a FBC and a coagulation screen including fibrinogen, prothrombin time, PT, and activated partial thromboplastin time, APTT. Further investigations are appropriate for girls who either fail to respond to medical therapy, or when an underlying pathological cause, or complications from acute or prolonged heavy bleeding is suspected. When suspicion of a bleeding disorder is high, this should include a von Willebrand disease screen and testing for factor VIII levels. A hormonal profile may help establish any underlying conditions that may be associated with an irregular bleeding pattern. An elevated thyroid-stimulating hormone, TSH, and low thyroxine level is consistent with hyperthyroidism, and an elevated prolactin more than 1,000 warrants further investigation. Where polycystic ovary syndrome PCOS is suspected, clinicians should measure their serum testosterone, sex hormone-binding globulin, SHBG, and calculate the free androgen index, FAI. STI screening and a urinary pregnancy test should be performed in sexually active adolescents presenting with abnormal vaginal bleeding with abdominal or pelvic pain, abnormal discharge or cervical excitation. In sexually active adolescents, swabs should be taken to assess for bacterial vaginosis, candida, chlamydia trachomatis, mycoplasma genitalium, Neisseria gonorrhoeae, and Trichomonas vaginalis. In the case of a positive result, girls should be treated in accordance with British Association for Sexual Health and HIV guidance and referred to a genitourinary medicine clinic for further virology screening, contact tracing and contraception counseling. Ultrasound is useful in characterizing pelvic masses or assessing congenital uterine anomalies. A pelvic ultrasound showing normal uterine development and normal, for age, adolescent ovaries can be very reassuring for both the girl and parents. Typically, transabdominal ultrasounds are performed, however, a transvaginal ultrasound may provide a more comprehensive assessment of the pelvis in girls who are sexually active. Pathological causes of heavy menstrual bleeding. Bleeding disorders. Bleeding disorders should be considered in adolescents presenting with any of the following: HMB from the onset of menarche, history of recurrent epistaxis, excessive bruising, prolonged or unexpected bleeding with injuries or surgical procedures, a family history of bleeding disorders, evidence of anemia, or failure to respond to conventional hormonal therapy. Von Willebrand disease is the most common bleeding disorder in the UK. Menorrhagia associated with von Willebrand disease may be worse following menarche owing to the dual effect of anovulatory cycles with underlying bleeding tendencies. There are three main types of von Willebrand disease. Type 1, the most common, is the mildest form and caused by a quantitative deficiency of von Willebrand factor. Type 2 results from a functional abnormality of von Willebrand factor, and Type 3 is associated with a severe deficiency in von Willebrand factor and factor VIII. Von Willebrand factor levels can rise with acute stress, inflammation, illness, or high-dose estrogen therapy. A hematology opinion should be sought when interpreting results in these circumstances. Immune thrombocytopenia, ITP, is the most common platelet disorder in adolescents, accounting for 7% of girls presenting with HMB. The diagnosis of ITP is typically made on a FBC and peripheral blood film to exclude other causes of thrombocytopenia. Inherited factor VIII and factor IX coagulation defects should be considered in adolescents with heavy menstrual bleeding and a family history of hemophilia. Although hemophilia is an X-linked recessive disorder, girls, carriers, may display bleeding tendencies. Rarer factor 2, 5, 7, 10, and 13 deficiencies may be considered if there is a positive family history, or the patient is of Ashkenazi Jewish descent. A clotting screen, PT and APTT, may guide further investigation with input from a clinical hematologist. Endocrinopathies. Thyroid disease. Hyperthyroidism is an important potential cause of HMB. Autoimmune thyroid disease affects 1 in 3,500 children in the UK. Other causes of hyperthyroidism include thyroidectomy, hypopituitarism, iodine deficiency, or radiation. Clinical features include heavy or irregular menstrual bleeding with a goiter, fatigue, myalgia, cold sensitivity, constipation, dry or thinning hair and skin, low mood, and reduced concentration. There may be a family history of thyroid disease or autoimmune diseases. The diagnosis is made based on elevated thyroid-stimulating hormone levels and low thyroxine with or without thyroid autoantibodies. Polycystic ovary syndrome. PCOS is a common metabolic disorder affecting 8 to 11% of adolescents. Hallmark features include oligo or amenorrhea, hirsutism, and acne. Prolonged unopposed estrogen exposure leads to proliferation of the endometrium, which becomes prone to heavy and irregular bleeding. Diagnosing PCOS in adolescents is challenging because irregular menstrual cycles, hyperandrogenism, and multifollicular ovaries are common in the healthy adolescent population. In 2023, revised international guidelines made specific recommendations to improve diagnostic accuracy and avoid overdiagnosis of adolescent PCOS. Connective tissue disorders. Ehlers-Danlos syndrome is a rare but recognized cause of HMB, with multifactorial pathophysiology including platelet functional abnormalities and weakness within the subendothelial collagen, altering platelet plug formation. Childhood-onset systemic lupus erythematosus, SLE, is associated with HMB in up to 50% cases owing to associated thrombocytopenia. Lupus anticoagulant hypoprothrombonemia syndrome is a rare complication of SLE, where acquired lupus anticoagulant and factor II deficiency result in severe bleeding tendencies. Case series reports describe prolonged or severe menorrhagia in adolescents with this condition, which were all successfully managed with tranexamic acid and steroids. Endometriosis. Endometriosis is a chronic inflammatory condition with variable manifestations in adolescence. Whilst endometriosis may be asymptomatic for some, the most common reported symptoms are dysmenorrhea, chronic pelvic pain, HMB, dyspareunia, and intestinal symptoms. Whilst endometriosis is not a common cause of HMB, where an adolescent presents with HMB and cyclical or chronic pelvic pain, endometriosis should be considered. It is an under-recognized consequence of many common chronic conditions and their treatments. Supraphysiological insulin treatment in type 1 diabetes, or hyperinsulinemia secondary to ovarian insulin resistance in type 2 diabetes, results in hyperandrogenemia and anovulation leading to heavy or irregular cycles. Optimizing glycemic control is associated with a reduction in menstrual dysfunction. Sodium valproate, carbamazepine, oxcarbazepine, and lamotrigine, used for epilepsy and bipolar disorder, potentiate androgen biosynthesis in ovarian theca cells, resulting in heavy or irregular bleeding. Enzyme inducers, for example carbamazepine, phenytoin, phenobarbital, rifampicin, and high-dose topiramate more than 200 mg per day, reduce the efficacy of combined hormonal contraception or oral progestogens, therefore increasing the likelihood of breakthrough bleeding and contraception failure. For individuals taking this medication, an intrauterine system like the Mirena or the depot-medroxyprogesterone acetate, DMPA, injection is recommended for those who are medically eligible. Vascular liver diseases including extrahepatic portal vein obstruction, Budd-Chiari syndrome, and portosinusoidal vascular disease are associated with clinical or biochemical hyperandrogenism, and 21% experienced HMB. Management of heavy menstrual bleeding. Most adolescents can be managed in outpatient care, however, admission to an acute gynecology or children's unit, for those under the age of 16, should be arranged if bleeding heavily, hemodynamically compromised, or significantly anemic, hemoglobin less than 80 grams per deciliter. Patients with HMB will be primarily managed by a gynecologist with a specialist interest in pediatric and adolescent gynecology. However, involvement of the multidisciplinary team including hematologists, endocrinologists, and psychologists should be sought in more complex cases. Outpatient appointments may be in person or virtual, and ideally timed to minimize schooling disruption. Consultations provide clinicians with an opportunity to educate girls about their menstrual and sexual health. HMB management should consider their physical, psychological, and social well-being. Although a parent or carer may be present during the consultation, Girls should be encouraged to make autonomous decisions about their treatment. It may be appropriate to discuss this with them alone. Verbal information should be supplemented with adolescent-specific leaflets or online resources. Pharmacological therapy. Non-hormonal therapy. Antifibrinolytics, tranexamic acid, 500 to 1000 mg 3 times a day, from the onset of menstruation for up to 4 days, is first-line therapy for HMB. It prevents excessive fibrin dissolution through blocking plasmin formation. In idiopathic HMB, tranexamic acid reduces mean menstrual blood loss by 47%. Tranexamic acid's effect on HMB associated with underlying bleeding disorders has not been systematically assessed, but it is commonly used. Side effects include gastrointestinal disturbances, and it is contraindicated in fibrinolytic conditions, convulsions, or thromboembolic disorders. Non-steroidal anti-inflammatory medications, NSAIDs, help to reduce HMB. There is no evidence of any particular NSAID being superior over another for this indication. Ibuprofen is readily and cheaply available over the counter, including at pediatric doses. Mefenamic acid is generally avoided owing to the dose-related increase in seizure risk. Iron replacement. Symptomatic iron deficiency anemia should be managed through iron replacement and dietary modifications. In most cases, iron should be replaced orally, with a dose of elemental iron of 3 to 6 mg per kilogram, maximum 200 mg, daily, given in 2 to 3 divided doses. Hormonal therapy. The UK medical eligibility criteria for contraceptive use guidance is used by clinicians to assess the safety of prescribing contraceptive treatments. When using established contraceptives for treating HMB, often alongside coexistent conditions such as PCOS, premenstrual dysphoric disorder, or possible endometriosis, the risk versus benefit profile of contraceptive agents vary, and clinical judgment must be applied alongside user preference and informed choice. Combined hormonal contraceptives, hormonal preparations containing estrogen and progestogen, are first-line treatments in adolescents without contraindications. Preparations can be taken cyclically or continuously, and include oral tablets, COCP, transdermal patches, or vaginal rings. If they wish, girls can time their periods and avoid bleeds during important times such as exams, holidays, or social events, which relieves anxiety and minimizes disruption to their education. When compared to placebo, the COCP reduces menstrual blood flow by 6 months' use. A monophasic COCP with 30 micrograms ethinyl estradiol and levonorgestrel is generally considered first-line. The diagnosis and comorbidities will help to guide preparation selection. Table 1. The ethinyl estradiol content can range from 20 to 35 micrograms. If a patient develops side effects related to estrogen excess, nausea, bloating, breast tenderness, vaginal discharge, then consider reducing to a 20 micrograms preparation, or moving to transdermal contraceptive. Higher rates of breakthrough bleeding are associated with lower estradiol doses. For progestogen-related side effects, acne, headache, depression, breast symptoms, consider switching to a non-androgenic progestogen. The vaginal ring may be a consideration in those with nausea or significant mood changes associated with the COCP. Combined hormonal contraceptives are commonly used as first-line therapy in adolescents with HMB secondary to bleeding disorders. They can help to regulate and establish predictable cycles and can also be used continuously in patients with bleeding disorders who present with anemia or acute heavy bleeding. In SLE, combined hormonal contraceptives are considered acceptable for patients in the absence of anti-phospholipid antibodies. If anti-phospholipid antibodies are present, progestogen-only preparations are an acceptable alternative and do not increase VTE risk. Progestogen only preparations. Progestogen-only preparations may be considered by adolescents with HMB seeking long-active reversible contraception, or those with contraindications to combined hormonal contraceptives. Desogestrel 75 micrograms once daily is the first-line progestogen-only pill for adolescents with HMB who do not want to, or cannot, take combined hormonal contraceptives. Amenorrhea is often desired by patients, which is only achieved by half to one-third of patients after 9 to 12 months. An unlicensed double dose, 150 micrograms, may increase amenorrhea rates and could be trialed after 3 months if required or desired. Side effects include breast tenderness or enlargement, low mood, reduced libido, acne, weight gain, and headaches. These may be more pronounced at higher doses. Norethistérone 5 mg 3 times a day or medroxyprogesterone acetate. 5 to 10 mg twice a day can be used cyclically to promote a monthly withdrawal bleed. It should be started on day 5 of the menstrual cycle and continued until day 26. Using progestogens, for example medroxyprogesterone acetate 10 mg daily for 12 days every 3 to 4 months, will induce a withdrawal bleed and protect against endometrial hyperplasia and HMB associated with prolonged anovulatory cycles. Norethistérone 5 mg TDS is associated with an increased risk of venous thromboembolism owing to its metabolism to ethinylestradiol. Norethistérone is associated with androgenic side effects. Where the CHC is contraindicated owing to VTE risk, medroxyprogesterone is preferred to norethistérone. The LNGIUS is more effective in reducing excessive menstrual loss than the COCP, medroxyprogesterone acetate, norethistérone acetate, mefenamic acid, and tranexamic acid. The LNGIUS can cause irregular bleeding for up to 6 months, but 65% have amenorrhea or reduced blood loss by 12 months. LNGUS users have higher quality of life scores than other medical therapies, and no higher rates of severe adverse effects. Evidence supports the use of LNGIUS in bleeding disorders and Ehlers-Danlos syndrome because of the high acceptability and amenorrhea rates. Cardiologist involvement should be sought in girls with increased risk of arrhythmias. Antibiotics are not routinely required to protect against infective endocarditis. The LNGIUS can be fitted in gynecology outpatients, however, specific groups may benefit from placement under general anesthesia, girls who are not sexually active or those with learning disabilities. Consideration should be given to the list order and location of postoperative care to minimize anxiety and maintain dignity. The hymen may become inadvertently stretched during the procedure, and it is important that girls and carers are aware of this possibility. DMPA is an appropriate alternative when the CHCs are contraindicated, when there are compliance difficulties with oral medication, or when other treatment has failed. Irregular bleeding may occur following the first injection, however 50 to 60% of users are amenorrheic at 12 months and 70% at 24 months. Prolonged use more than 5 years may be associated with irreversible osteopenia, and it is associated with higher rates of weight gain than other treatment options. The risks and benefits should be considered and it requires regular review. Cyanopress is a subcutaneous depot injection of medroxyprogesterone acetate which can be self-administered. The etinogestrel-releasing implant is a contraceptive device not licensed in the under 18 age group, but its use as a contraceptive is supported by the Faculty of Sexual and Reproductive Healthcare from age of menarche. The resulting bleeding pattern is unpredictable and for some may be frequent or prolonged. For this reason, it is not used as a treatment for HMB. Consent in adolescence. Safe care in adolescence depends upon understanding the principles of consent and capacity. Effective communication is required for the adolescent to provide informed consent. Information regarding their condition, the proposed treatment or investigations, likelihood of success, risks, and alternatives including the right to obtain a second opinion should all be provided in a way appropriate to the patient's age and maturity. For an individual to be deemed to have capacity, they must be able to understand the proposed treatment, understand the risks, benefits and alternatives, weigh up and retain the information, and communicate their decision freely. A consent form will be needed for insertion of an LNG-IUS under anesthetic. In the UK, young people over the age of 16 can provide consent using an adult consent form 1, provided they are deemed to have capacity. For those aged 14 to 16 years, a consent form 2 for children should be used where the parent provides consent for treatment, although the child is encouraged to sign to show their understanding of the treatment and to move towards shared decision-making. Follow-up. Following their outpatient appointment, patients should be provided with a written copy of their treatment plan and point of contact. Brit SPAG recommends that adolescents should have a medical review 6 months after starting hormonal therapy. The review should focus on their current symptoms and change over the past 6 months, compliance to therapy, acceptability of treatment, and the impact of their symptoms on their quality of life. Special circumstances. Adolescents with HMB and learning disabilities. Girls with learning disabilities may find monthly bleeds distressing and problematic to deal with hygienically. Continuous or long-acting preparations with high amenorrhea rates, or where bleeds can be scheduled, are preferred. Continuous extended use CHC is a popular choice to reduce menstrual severity, pain, and allow scheduling of withdrawal bleeds. Consideration should be given to comorbidities and drug interactions, especially anti-epileptic enzyme-inducing medications. Transdermal CHC preparations are an option when there is difficulty taking tablets. DMPA has high amenorrhea rates and is suitable for girls in whom CHC is contraindicated, but the risk of osteoporosis should be considered. The LNG-IUS is an appropriate alternative but would usually need to be placed under general anesthesia. Girls with learning disabilities will usually be accompanied by a parent or carer. However, the consultation should be directed with the girl as much as possible. Information should be delivered multimodally using verbal, visual, and written information appropriate for their intellectual abilities. Hospital learning disability teams may attend appointments to support medical teams. Independent patient advocates should be sought in best interest discussions. The management of acute heavy menstrual bleeding. Acute heavy menstrual bleeding is a medical emergency and initial management should focus on stabilizing the patient hemodynamically. Most patients will present to the emergency department where they will be triaged to a monitored area. However, if they present to an acute gynecology or pediatric assessment unit, then senior nursing and medical staff should be alerted to enable an urgent review. We recommend that clinicians use a systematic approach in acute hemodynamic compromise, and in the absence of a national guideline, we suggest the management pathway outlined in Figure 1. A full blood count, coagulation screen, group and save, urea and electrolytes and venous blood gas should be taken for analysis. In the instance of significant anemia, HB less than 80 gdl, or bleeding with hemodynamic compromise, blood products should be replaced. Group-specific packed red cells are transfused as first line. Platelets may be indicated in severe thrombocytopenia, less than 50, or in known platelet disorders. Clotting factor replacement, plasma-derived or recombinant factor-specific, may be indicated if there are severe deficiencies. The blood transfusion laboratory and on-call hematologist should be consulted for guidance, particularly if there is a known clotting disorder. When the patient is hemodynamically stable but symptomatic and has moderate anemia, HB 80-100 grams per deciliters, an iron transfusion is appropriate. A targeted clinical history should elicit the onset and severity of bleeding, associated symptoms, anemia, pelvic or abdominal pain, history of gynecological conditions, bleeding disorders or medical conditions. A drug history, including prescribed and non-prescribed medications, should be elicited. Clinicians should take a sexual history to assess the patient's risk of pregnancy, sexually transmitted infections, or sexual assault. A clinical examination should be conducted in the presence of a chaperone. The abdomen should be palpated to exclude abdominal or pelvic masses, and pads or towels inspected to assess ongoing bleeding and estimate total blood loss. If trauma is suspected, then the vulva, vagina, and perianal area should be inspected. It may be appropriate to do this under anesthesia to aid full evaluation and repair. The child safeguarding lead and police will need to be informed in the instance of sexual assault and appropriate forensic swabs taken. Injuries should be documented on a standardized body map. Hormonal therapy is first-line treatment in the management of acute HMB, and various options are available. Both CHC and oral progestogens are effective. However, common UK practice is to use oral progestogen as first line. A single retrospective study comparing medroxy progesterone acetate 20 mg TDS versus 1 mg norethindrone and 35 micrograms ethanol estradiol TDS found that bleeding had ceased in 88% of the CHC group and in 76% of the progestogen group within 3 days. A further review found no benefit to high-dose CHC versus standard dosing CHC, once daily, in shortening bleeding time, therefore standard dosing should be considered first line. Norethindrone 10 to 30 mg daily is a safe alternative to medroxy progesterone. Tranexamic acid 1 gram orally or IV TDS is commonly used in the acute setting, however there are no studies evaluating its use in adolescent acute HMB or in bleeding disorders. Nevertheless, it would be reasonable to consider in adolescents without contraindications. Surgical therapy for acute HMB is rarely indicated, however there are case reports where Foley catheters provided intrauterine tamponade in girls with acute anovulatory perimenarchal bleeding and underlying bleeding disorders. Girls should remain inpatient until the bleeding has stabilized. We recommend performing a pelvic ultrasound and screening for underlying bleeding disorders given their higher prevalence in the hospitalized population. On discharge, a robust follow-up plan should be devised on discharge, including ongoing medication planning, contact details for clinical nurse specialists and online resources, and a follow-up review planned in a pediatric and adolescent gynecology clinic, if available, or by a gynecologist with expertise in caring for adolescents. Figure 1. Algorithm for the management of acute heavy menstrual bleeding. Pathway 1. When there is evidence of hemodynamic compromise. Pathway 2. When there is no evidence of hemodynamic compromise. Conclusion. HMB is a common condition affecting adolescent girls. It has vast physical, psychological, and social implications. Untreated, it has the potential to have a significant impact on future education and employment attainment, contributing to the gender health gap. Adolescent HMB is most related to HPO axis immaturity, however, bleeding disorders, endocrinopathies, endometriosis, and PCOS can all present in adolescence. Tranexamic acid, NSAIDs, and hormonal therapy are the mainstays of treatment.